Welcome. Today we're going to be talking about the internal brace ligament augmentation repair for the treatment of ankle instability. We have with us in the studio today Dr. Chris Coetzee from Edina, Minnesota, Dr. Troy Watson from Las Vegas, Nevada, and Professor Gordon Mackay from Stirling, Scotland. Welcome, gentlemen.
Thank you.
So Chris, can you review with us how surgeons treated ankle instability prior to the internal brace?
I think most of us used the Brostrom or modified Brostrom and the Gould modification in some form to repair for primary ones. And as you know, the ones that failed, we then used either allograft or autologous graft anatomic reconstruction.
So Troy, how have you felt that the short-term and long-term results with the standard Brostrom Gould repair have been?
Well, I think all of us would agree on this panel that prior to internal brace, our Brostroms did very, very well. But the truth of the matter is that we followed these patients for a short period of time. Long-term studies have been rather deficient in the literature. There's one good study that was a 9-year follow-up by Mafuli, published in the Journal of Sports Medicine, and that study showed that 58% of patients were able to return to their pre-injury level of activity. But on the flip side, that means 42% were not able to return and had to modify their activities. So clearly these patients don't do as well as we think they do.
Along the same lines, a very interesting true story is I in Minnesota treated 2 of the university female athletes for ankle instability with Brostroms, and after about 6 months they went away and did fantastic. And with all these issues about the conventional Brostrom, I asked them to come back to the clinic, and I examined both of them, and both of their Brostroms were loose. So I asked them, so why didn't you come back? And said, well, everybody's telling me I'm doing fine. But from a stability point of view, they were not as stable as when I saw them 5 years earlier.
Were they functionally complaining of instability? Or
they were obviously not college athletes at the moment, but with recreational stuff, both of them complained about functional instability, but they didn't realize that it's possible to go back and do something about it.
So Gordon, can you describe your reasoning and decision to start utilizing the internal brace in your practice over the last 3 to 4 years?
Well, I was quite convinced, having experienced a period of time in cast myself, that immobility is detrimental to joint function. So I think I was looking for an alternative that would allow early mobilization while the ligament was healing so that rehabilitation could start immediately. And the internal brace seemed the ideal way to progress.
So Troy, do you have any concerns with the current Brostrom repairs?
Well, again, before internal brace, we would do a simple Brostrom. I typically use suture anchors for that. And sometimes when you get in intraoperatively, you notice that the tissue isn't of great quality. And so you're kind of tying down your sutures and noticing that you have really thin tissues there that might not stand up to the test of time. And you know that you need something else. So in the past, I would do a modified Evans. I would split my peroneal brevis tendon and take one arm of that and run it through the fibula, and that worked, but still there were some downsides to that operation with stiffness through the subtalar joint and potential arthritis of the subtalar joint. So.
Yeah, I do emphasize your point. If you do a Brostrom, and some of them you open the tissue and it's nice thick scar tissue, and those I think will do well because you have very good tissue that you can anchor or double suture, but sometimes you open and it's very flimsy tissue. So to a Brostrom in that situation will not work. You can just as well kiss your mother-in-law.
No.
Gordon says no.
So for those cases and for generalized ligamentous laxity, Marfan's, or any of those conditions, to do a primary Brostrom you know will not work. It will eventually stretch out.
So in the past, in that patient population, I was doing a split Evans and taking an arm and putting it through the fibula and fixing it with a biotina screw, which has some inherent problem.
The problem with that is if you have a generalized ligament lax person or Marfan's or with the genetic abnormalities, even that tissue stretches out.
Sure.
That's a real problem, and you have to be very careful how you approach ligamentous reconstructions in that patient population.
Well, Chris, what were your initial impressions of the internal brace?
Well, that's an interesting story. I think you both were at that same meeting with Arthrex in London, and Tom Clanton gave a talk about internal brace, and I sat there in the audience and I was absolutely appalled.
I think we sensed your body language even in a big hall. His hair stood even more on end.
When I started my orthopedic residency was at the end of the Gore-Tex era for cruciate ligament reconstructions, and it sounded good initially, but all of those failed, and they failed miserably because it was an intra-articular ligament, and the entire ligament was just the Gore-Tex. So I walked up to him afterwards and said, "You're old enough to remember the Gore-Tex days. These will not work. They will fail." And he said, "Sit down, calm down, get your blood pressure down. Let me explain. The internal brace is not the repair. You still do a Brostrom repair. The internal brace is there to protect your repair while biology happens." And it took me a while to digest that, and eventually I thought, well, maybe it makes sense. I could maybe try it.
Gordon, we often hear, "I've never met a Brostrom that needed augmentation," or "my Brostroms all do well." What are your thoughts on that?
I think if you take the patient's perspective, you see it quite differently. I think we wanted some evidence to see that the internal brace was necessary, and there was an excellent study carried out at the Stedman Philippon Research Lab that confirmed that direct soft tissue repair to bone using anchors wasn't enough to support early mobilization. So it made sense to me that you protect your repair during that early phase to minimize the risks, and so as a surgeon you can sleep easy.
So Troy, it's understood that this is a relatively new procedure without long-term follow-up. What has been your experience with your patients?
Number one, I would say, although it is a relatively new procedure, the implants that we're using, the fiber tape, the swivel locks, have been used in the knee and shoulder for some time, thousands of cases. So we have confidence in using these implants. As far as patient outcomes, both on the short and long-term side, what we're seeing is phenomenal recovery times. That's when I got excited about it. I did my first patient and was able to see that patient basically running down the hallway at 6 weeks, where usually I'd be just taking them out of their cast for a modified Brostrom procedure.
And I can tell you my first experience. It was after my meeting with Tom Clanton. I saw one of my patients back that I did a Brostrom on that failed, and then I did an anatomic reconstruction with an allograft that failed, and then I did a reconstruction with an autologous hamstring that failed. So 3 failures that I did. So I thought it was well done every time. We did all the right rehabilitation. So I was basically with my back against the wall, and I decided I will try this and show Tom Clanton that it doesn't work. So did the ligament reconstruction, and then at 2 weeks she came back and she said, I have almost no swelling. I feel much better than with any of the other repairs, and I unfortunately forgot to use my crutches for the past week. So she's been full weight bearing after the first week, feeling like she did after 3 months with the other repairs. So that made me think a little bit. So I did a few more of previous failures before I did my first for a primary repair. And I have the same opinion. I think the initial rehabilitation is spectacularly quick, and the patients do better at every time interval.
Gordon, same?
If the surgeon has the confidence and they can share that with their patient to allow this early movement that we've all observed, then as soon as that swelling sort of settles, the joint stiffness and the capsular irritability seems to ease, and then it's translated into a normality of gait. And once they're walking normally, you're getting away from that limp and that dysfunction that often perpetuates a pain cycle. So I think if we can, when we observe this in shoulder surgery and knee surgery as well, stability and early mobilization just eases the joint and provides comfort. And with comfort, you get much less muscle wasting.
I would agree with that. I think it's the early range of motion. I really do. How we're getting them moving much more quickly than we ever have.
I've obviously observed a dramatic change in terms of my patient outcomes. They're much more comfortable, there's a much smoother return to work and to sport. So we give them a fantastic start. So it means that after surgery they can just lift quickly in terms of recovery rather than going into that valley that you normally would after prolonged immobilization and surgery that you have to crawl out of gradually over months and months. So I've been delighted with outcomes, but I wanted to look at it a wee bit more objectively. And the surgical outcome system which I use, which gives me the independently validated outcomes in my patients, has confirmed this, and I've had the pleasure recently of just having a paper accepted with Bill Ribbons confirming the change that this has made to my practice.
So Chris, can you comment on the status of your retrospective and prospective randomized studies that you're doing with the internal brace?
With the retrospective part, we're looking at everybody that's more than 6 months out, and we do a very good functional test on all of them, and also the same kind of outcome studies But it is retrospective, and we know for power analysis we need a prospective randomized study. So the idea is to do a prospective randomized study, conventional brostrom with brostrom augmented with an internal brace. And we are almost finalized with protocol for the study, which created quite a bit of problems because with the rehabilitation part of it, you want to compare apples to apples, and we know we can push the internal brace people very quickly. We cannot do that with brostrom, so we will have to find some form of middle ground to make it a good study but not compromise the original brostroms.
The improvement has been so marked in terms of the patient's function, it does create a challenge to then go back and say, really for the purposes of evidence here, we would like to suggest that we try route A or route B when we know certainly accepted that there's been such a dramatic change in practice. So I think that's a challenge. I think that's a real challenge, but a very interesting bit of research.
So Chris, in terms of tensioning the internal brace and any technical pearls, additional technical pearls?
I feel very strong that you should never over-tighten. If you want to make a mistake, it can be a little bit loose, but never over-tighten because then the ligament cannot mature normally.
I agree.
So when you put your second swivel lock in, so that's in the fibula in my case, your ankle should be at 90 degrees. You can mark on your inserter on the black line, the fiber tape, you mark it at that level and then just move it down when you insert it. And before you start to turn it in, put a freer or something under the fiber tape to make sure it's not too tight, because at that point you can still adjust. Once it's in, it's hard to adjust.
Chris, I agree totally with that. And I think it's strange, it seems like a small point, but it's probably one of the most crucial parts of the procedure to get that tensioning right. And actually, when we initially were suggesting that we went from the fibula and did the talus last, it was sometimes difficult getting the anchor in.
Exactly.
And the temptation was to add a wee bit of brute force. And we did that, often you would really tension up the internal brace. Doing it the other way around and doing it that way where you use the laser line to measure the depth of the anchor, factor that in and lengthen the tape and then insert gently with just manual pressure, I agree, just consistently gets you the same result. Appropriate tension to act as a restraint or a check rein, but doesn't strangle the soft tissue repair.
And I've come to just take a hemostat and I put my hemostat underneath to the thickest portion of the hemostat. And then I do use a mallet, and I melt it to the edge, and then screw it in, and it's reproducible every time I have the same amount of tension. And your foot position is key. You know, positioning the foot, no eversion, which is what we're kind of taught when we're doing our brostrom. So,
I just want to add one thing. When you're done with your anterior talofibular part, it's always good to test your calcaneofibular ligament, see if there's talar tilt instability, and if there is, then I will add a calcaneofibular leg to it.
Yeah, that's a good point.
Yeah, I think that's an excellent point.
Chris, what is your indication for using the internal brace with your lateral ankle instability cases?
It started off using it for failures, so where I would have used anatomic reconstruction with allograft, or people with Ehlers-Danlos or some generalized ligamentous laxity. But now probably 70% of even my primary brostroms I do internal brace just because the rehabilitation is so much quicker.
What about you, Troy? Same?
When I started out, I think I was really doing it on the same patients that I was doing that split perineal tendon procedure on, and that's how I kind of got comfortable with using the technique. But I realized how well these patients did, so I do it on all my primaries now.
I agree. I do know. I find it hard to justify to the patients why I wouldn't add an internal brace for them. And that is what their expectation now is, a nice, smooth and accelerated recovery. So I will use it routinely.
Describe your post-op rehab protocol with or without the internal brace.
Initially, without the internal brace, so now we're just talking about kind of the old school way that we used to do it. So for my modified brostrom ligament repairs, I would typically splint them for anywhere from 7 to 10 days. They'd come back to the office, and I would typically put those patients actually into a cast for 3 weeks, and then they would show up at my office somewhere between 4 and 5 weeks, take them out of the cast, put them in a cam walker boot, and begin aggressive physical therapy at that point. So we're usually around 4 to 5 weeks out. Now, my post-op protocol is 5 to 7 days in a splint, and they come back to the office. They get a cam walker boot for the next 2 weeks. I'm beginning already range of motion, their full weight bearing, and into a shoe with an ASO ankle brace at the 3-week mark.
You gentlemen had similar experience with your post-op rehab protocol?
Oh, absolutely. With conventional Brostrom, I cast them for 2 weeks. They can be full weight bearing right away. So as soon as they're comfortable, they can be full weight bearing. In 2 weeks, I go in a cam boot for 4 weeks. From week 3 to 6, they can do active range of motion, no passive range of motion. So we start physical therapy only at 6 weeks. With the internal brace now, they are on a boot. It's still for 2 weeks just because that's when I see them back. But I tell them they can get out of the boot whenever they want and start active range of motion right away. In 2 weeks, they start with active and passive range of motion and physical therapy. And at 4 weeks, we're done with them. And you know, a lot of our athletes have the ability to go to a zero gravity treadmill. So that's a wonderful way to start, which you can do right away.
I agree, actually. It's transformed the recovery and rehabilitation for patients. In theory, the strength of the internal brace is equivalent to the ATFL, so I reassure them that the stability and strength is there. And as we discussed earlier, it's more about comfort and function. Some patients are very comfortable very quickly. Certain athletes will come into your room even after a fortnight and they just walk normally into the office and sit down. So the difference in terms of their recovery is remarkable, and we can accelerate the rehabilitation from that point. And it does seem to be that different. And certain patients, especially those in terms of performance sport, can be back to contact sport as early as 8 weeks, although the average recovery in my clinic is somewhere between 10 and 12 weeks.
Patients with generalized ligamentous laxity, very comfortable using the internal brace?
Actually, because I'm always concerned that because of the natural elasticity of the tissues, that we can get good function, but often it's a transient good function. So we can find 2 to 3 years we're getting that attenuation of structure. I think for several reasons. One, they can maintain function, and we don't get the same disability because they usually have other joint issues. So you want to keep them mobile, so the internal brace affords that for them, an accelerated recovery. But I definitely think it protects you from that attenuation and that secondary disability. So I'm hopeful that not only initially will it protect them, but we'll have a longer term benefit from that little bit of internal armour.
So Troy, what are your thoughts about using the internal brace versus doing a full allograft reconstruction with tenodesis screw fixation?
To be honest with you, Chris, the last 18 months I've done no allografts, and I think that that's in large part due to the internal brace and the stability I'm seeing and the quick rehab that we're seeing. So whereas we used to do plenty of allograft reconstructions for some of these difficult cases, revisions, the generalized ligamentous laxity patients, now we're doing internal braces and seeing similar results.
I agree. I have not done a single allograft since I started to use internal brace. It is so much easier to do, for one. The recovery is completely different. We know if you use allograft, you have to let that tissue mature and get vascularized. And that can take 6 months or longer before you can really let them go back. So there's, to me, no comparison. I don't know if I will ever use an allograft again for a lateral ligament reconstruction.
That's a great thing if we never are doing allografts anymore. I think that there will still be an occasion for that, but right now I have not done one in the last 18 months.
So Gordon, we know that the internal brace is being applied to other joints in the body. Could you comment on a few of the applications in other parts?
I think if we find that we can encourage the biology of healing by providing a scaffold and early mobilization, then that is transferable to ligament injury wherever it happens to be in the body. In the upper limb, for example, just most recent addition was gamekeeper's thumb, and the idea that you can repair the ulnar collateral ligament and then restore immediate movement instead of 6 weeks immobilization, clearly has a big impact on patients. Dislocations and elbow injuries, instead we used to be concerned about contracture and stiffness after surgery, but by being able to internally brace the ulnar collateral ligament, we can mobilize immediately. Even for the sternoclavicular joint, which used to require 6 weeks, often in a sling or even longer if surgeons were being very conservative, if we add the internal brace to the AC joint as well as reconstructing the ligaments, patients can wash their face, clean their hair, etc. without any significant restriction or discomfort. So it has a massive impact on all of these areas. The other area, just very quickly to touch on, is the knee, and we've started off repairing the collateral ligaments and stabilizing the patella to minimize donor site morbidity and ligament harvest. But the holy grail really has been cruciate ligament repair. And it was believed that this wasn't really possible. But basic science has shown that using a scaffold and allowing the natural tissues to heal, it was possible for the ACL to recover. And now we've been following this through. We're finding excellent results in terms of function and recovery. And we really are increasingly keeping standard reconstruction as a salvage procedure rather than a primary operation, especially in our younger patients.
Troy, any others?
I'm equally excited about mid-substance Achilles tendon repairs that we're now doing. So we're putting suture proximally in the tendon, nothing in the distal segment, and then bringing our sutures down through the tendon and putting them into swivel locks in the calcaneus. And just like we're seeing with the internal brace, the rehab's quicker, there's less pain and morbidity associated with it, and we're doing these through very small incisions now. So that's an exciting avenue for the internal brace construct. We also are using it medially in the ankle and flat foot reconstructions. I have great experience in that, and it's really helping add some support medially to the spring ligament. So there's another application. Chris, you might have another.
I've used it for deltoid ligament reconstructions as well. I still find it very hard to reconstruct a deltoid, and this is a very good augmentation to that.
So, gentlemen, final thoughts. Gordon?
I mean, I've been amazed by the difference it's made from patient care especially, and the restoration of function. And I love the idea that we're avoiding some of the secondary disability that might have been their fate if we hadn't taken this path. So I am an enthusiast, but without overstating it, it has transformed my practice and the care of my patients, and I'm a big fan.
Yeah, I think anytime we can make our patient experience better, we've done a huge service. And I think internal brace unquestionably has done that for all of us. You've heard the stories, and the smiles that we see as a result of that are meaningful. So it really is a game-changing device.
I can just echo that. I think it's the most exciting new technology that I've dealt with in the last 10 years.
Amazing. Gentlemen, thank you so much for joining us again today.
Thank you.
Thank you once again for being part of this breakthrough event and for letting Arthrex help you treat your patients better. A team of Arthrex experts will remain online to answer any additional questions you may have. Also, all the digital assets in this webcast will be available on the arthrex.com website. If you'd like to view this webcast again, subscribe to our What's New email using the form provided after the broadcast. We also encourage you to contact your local Arthrex representative to arrange a visit to one of our surgical training facilities around the world to learn more about the internal brace. We look forward to hosting you again at the next exciting edition of Breakthrough.